Welcome to the deep dive. Today we're diving into a really significant health topic, venous thromboembolism, or VTE.
Right.
That's basically the umbrella term covering deep vein thrombosis, DVT, blood clots, usually in the legs,
hmm
and pulmonary embolism, PE, which is when those clots travel up to the lungs.
Exactly. A very serious complication.
Yeah, it might not be top of mind every day, but, in the U.S., we're talking hundreds of thousands of cases each year. And tragically, at least 100,000 deaths. It's pretty stark when you hear the number.
It really is. And the impact, well, goes way beyond the human cost, sadly. The annual expense for treating VTE just in the U.S., it's estimated around $10 billion.
Wow, 10 billion. So it's a huge challenge for the healthcare system, too.
Definitely. A major economic burden alongside the human one.
And this isn't new, right? The medical community has been aware of this for a while.
Oh, yeah. Way back in 2008, the U.S. Surgeon General flagged DVT and PE as major public health problems, called for better prevention. And then, more recently, in 2016, the Agency for Healthcare Research and Quality, AHRQ, they pointed to VTE as a leading preventable cause of death in hospitals.
Preventable. That's the key word there, isn't it?
That is absolutely the crucial word. And that's what this deep dive is all about today. We've got some excellent source material here, chapters from a top medical textbook, Rutherford's Vascular Surgery.
Right.
And our mission really is to unpack the key aspects of VTE prophylaxis. That's the prevention part. We want to explore who's at risk, how doctors figure that out, and the different methods they use to try and stop these clots before they even start.
So the goal is to give you, the listener, a really solid understanding of what's going on in this field.
Exactly. To make sense of the risks and the strategies.
Okay, let's get into it then. Why the whole process of risk stratification and prophylaxis? I mean, why not just treat everyone the same? Why figure out who's high risk?
Well, that's a great question. The thing is, we've actually identified quite a few specific factors, some related to the patient themselves, their underlying health, and others related to, say, a procedure they might be having. And these factors reliably increase the chance of developing VTE. So because we know these, we can actually create a sort of individualized risk profile. It lets us tailor the preventative approach.
Okay, so we can kind of predict who's more likely to get a clot.
We can get a much clearer picture, yeah. It's not perfect, but it's much better than a one-size-fits-all approach.
And these risk factors, have they changed much over, say, the last couple of decades?
The core ones have been remarkably consistent. Things like surgery type, immobility, previous clots, those have been known risks for a long time.
Right.
But one major new factor did emerge recently, and that was, of course, the COVID-19 pandemic.
Ah, okay.
Yeah, being infected with COVID itself turned out to be a pretty significant high-risk condition for developing VTE.
That makes sense, given everything else we saw COVID doing. So the textbook breaks these risk factors down into categories, right? Strong, moderate, and weak.
That's right. It's a helpful way to organize them.
Can you give us some examples? What falls into that strong category? The really high-risk stuff?
Sure. So strong risk factors, these are things that really significantly bump up the VTE risk. Think about major events like a hip or leg fracture, or having a hip or knee replacement surgery, major general surgery, major trauma like a bad car accident, or a spinal cord injury.
Wow, those all sound really serious. Is there data showing just how much they increase the risk?
Oh, absolutely. There's actually a fascinating, very early trial from 1959. It looked at hip fracture patients.
1959, wow.
Yeah, and they found in the group that got no preventative treatment, the control group, a staggering 29% developed VTE.
29%.
But in the group that received a vitamin K antagonist, a type of blood thinner, only 3% developed VTE.
Huge difference.
A dramatic difference. It really showed early on how effective prophylaxis can be. And we also know for surgery, there's a pretty linear relationship. The longer the surgery, the higher the VTE risk.
Makes sense.
And for major trauma patients, the DVT rate is quite high, maybe 12% within 2 weeks. Spinal cord injury, even higher, around 35–40% within 3 months.
So it's that combination of injury, inflammation, and immobility. Yeah.
Exactly. Significant physical disruption impacting blood flow and the body's clotting system.
Okay, those are definitely strong risk factors. What about the moderate ones? What fits in there?
Moderate risk factors cover a wider range. Things like active cancer and undergoing chemotherapy.
Okay.
Having had a VTE before, that's a big one. If you've had a clot, you're about 8 times more likely to get another one.
8 times, wow.
Yeah. Then there are thrombophilias. These are inherited or acquired conditions that make your blood more likely to clot.
Like factor V Leiden.
Exactly. Factor V Leiden is a common inherited one, gives about a 10% lifetime VTE risk. Others include prothrombin gene mutation, deficiencies in protein C or S, antithrombin deficiency, and acquired ones like antiphospholipid antibodies.
Okay. What
Other
else?
moderate risks include congestive heart failure. The risk goes up as the heart's pumping function, the ejection fraction gets lower. Respiratory failure, using hormone replacement therapy or oral contraceptives, and also the postpartum period after giving birth.
That's quite a list. Anything particularly stand out there in terms of frequency or impact?
Well, the cancer link is really significant. One study on abdominal cancer surgery patients found a 2% VTE rate, which might sound low, but VTE was actually the cause of death in nearly half the deaths they recorded.
That's sobering.
It is. And chemotherapy adds risk, too. For instance, breast cancer patients having both chemo and surgery triple the VTE risk compared to surgery alone.
Right.
And with oral contraceptives, it's worth noting the risk varies. It depends on the dose of ethinyl estradiol. Lower doses generally mean lower risk.
Good to know. Okay, finally, the weak risk factors. These are less impactful on their own, I guess.
Exactly. They contribute, but maybe not as strongly as the others unless they pile up. So weak factors include things like prolonged bed rest, general immobility, even just sitting for a very long time, or having your leg in a plaster cast.
Even a cast.
Yeah, it restricts movement and blood flow. Also, increasing age, the risk basically doubles every decade after age 40.
Opals. Okay.
Obesity is listed as weak, though some studies have had conflicting findings on the strength of that link. And varicose veins, particularly in cancer patients, seem to add some risk too.
So it's really about the whole picture, adding up these different factors.
Precisely. Which leads us to how doctors actually use this information.
Right. The risk assessment models, how do they work? The goal is to balance the clot risk against bleeding risk from the treatments, yeah?
Exactly. You don't want the cure to be worse than the disease, so to speak. There are a few models out there. A simple one is the three-bucket model.
Low, moderate, high risk. Seems intuitive.
Pretty much. It uses a mix of patient factors and procedure factors to slot someone into one of those three buckets and then suggest different levels of prophylaxis.
Okay. And the other one you mentioned, the Caprini score. I feel like I've heard of that.
Yeah, the Caprini score is quite widely used. It's more granular. It assigns points to a whole list of different risk factors.
Okay.
You add up the points, and the total score gives you an estimated risk level. 0, 1 is low, 2 is moderate, 3, 4 is high, and 5 or more is considered highest risk. Historically, that highest risk group had a really significant chance of DVT without any prevention.
So higher score, higher risk. Makes sense. But the text mentions something about it being historically derived. What's that about?
That's a really crucial nuance. The original Caprini score data came from studies where most patients didn't get routine VTE prevention.
Ah, because we do that much more now.
Exactly. So today, the actual chance of getting a VTE with a given Caprini score is probably lower than those original estimates suggested because prophylaxis is so common.
But the score is still useful.
Oh, definitely. A big analysis in 2017 confirmed that higher Caprini scores still strongly correlate with increased VTE events after surgery. And, importantly, it didn't find that a higher score meant a higher risk of bleeding after the operation.
Okay, so the score still helps identify who needs prevention most, even if the absolute percentages have changed.
Precisely. It guides the decision-making.
Right. So once we've used these models to figure out the risk level, what are the actual tools, methods of prophylaxis? We've got mechanical and pharmacologic, the drugs.
Correct. And the risk level tells us whether to use mechanical methods, pharmacologic methods, or, quite often, a combination of both.
Let's start with the mechanical methods. First up, elastic compression stockings. The classic TED hose.
Right. Everyone's probably seen those. They work by applying graduated pressure, tighter at the ankle, looser up the leg.
Squeezing the leg, basically.
Yeah, it reduces the diameter of the veins, which makes the blood flow faster, less chance for it to pool and clot. The ideal pressure is about 18 millimole Hg at the ankle, down to 8 millimole Hg at the thigh.
And do they work well on their own?
Well, the evidence is a bit mixed. A major Cochrane review found they do reduce DVT rates compared to nothing. But they seem to work better when combined with something else.
Okay.
Like adding stockings to another method significantly lowered the DVT rate compared to the other method alone in that review. Other analyses agree stockings help, but combining them with, say, medication seems to give the best results.
What about for patients who aren't having surgery, like medical patients in the hospital?
There, The evidence is even less clear. One study in stroke patients found no VTE reduction with stockings, but did see more skin problems.
Skin breakdown.
Yeah, exactly. And thigh-high stockings can be uncomfortable. Sometimes they roll down and create tight bands, which isn't good. So overall, the enthusiasm for using only stockings has kind of waned a bit. And you definitely shouldn't use them if someone has severe leg swelling, bad dermatitis, or peripheral artery disease, poor circulation in the arteries.
Okay, makes sense. Next mechanical method. Intermittent pneumatic compression, IPC. The inflatable leg squeezers.
That's them. Inflatable sleeves or boots connected to a pump. They inflate and deflate rhythmically.
Like a massage for your veins.
Sort of, yeah. That intermittent pressure helps push blood through the veins, increasing flow. And interestingly, it also seems to stimulate the body's own clot-busting system, fibrinolysis.
And how effective are these?
IPC is generally seen as the most effective mechanical method for preventing DVT after surgery. The American College of Chest Physicians, the ACCP, estimates significant VTE reduction with IPC in high-risk non-orthopedic surgery.
Right.
They recommend it either alongside drugs or even alone if someone can't take blood thinners due to bleeding risk.
What about in orthopedic surgery, hip and knee replacements?
There, the guidelines often recommend IPC plus pharmacologic prophylaxis for many patients because the risk is so high. Studies show IPC alone cuts DVT rates significantly compared to no prevention, maybe by as much as 60% in some analyses.
Sounds pretty good. Any downsides?
Similar potential for skin injury if they don't fit right or rub. So caution with skin issues, severe swelling, or artery disease. There's a theoretical worry about dislodging an existing clot, but there's not really strong evidence for that being a major problem.
Okay.
The bigger practical issues are patient comfort and compliance. Sometimes people take them off because they're bulky or noisy, or don't put them back on correctly after getting up.
Right.
And it's also worth noting, while good for DVT, some studies, like in neurosurgery or stroke, haven't shown IPC clearly reduces PE, pulmonary embolism.
Interesting distinction. Okay, what about foot compression devices? Are they different from the leg IPCs?
Yeah, they're smaller, like inelastic slippers or boots that inflate rapidly just around the sole of the foot.
Just the foot.
Right. The idea is that rapid inflation pushes blood out of the foot veins, which helps flow higher up the leg and reduces stasis. They do reduce DVT compared to nothing, but generally medication works better.
So maybe a niche use?
Possibly.
Right.
Maybe in trauma patients who can't have anticoagulants and can't wear leg IPCs due to injuries.
What about just walking? Ambulation seems like the simplest thing.
It does, and getting patients moving early is definitely good for lots of reasons.
Nuts.
But, surprisingly, there's no strong objective data proving that walking alone significantly reduces VTE risk.
Really?
Yeah. So while we encourage it, it's crucial not to rely only on ambulation, especially for high-risk patients. You still need the proven methods.
Good point. Okay, last mechanical one. IVC filters. Inferior vena cava filters.
Yeah.
These don't prevent the DVT itself, right?
Correct. They don't stop the clot forming in the leg. They're tiny filters, placed in the big vein, the IVC, that carries blood from the lower body back to the heart.
Like a net.
Exactly. They're designed to catch large clots that break off from a DVT before they can reach the lungs and cause a PE. So it's PE prevention, not DVT prevention.
And who gets these?
It's a very select group. High-risk patients, usually severe trauma patients, who are at high risk for PE, but absolutely cannot be anticoagulated because of bleeding risk. Some studies in trauma showed they reduced PE and fatal PE, but didn't change DVT rates. But their use for primary prevention has decreased as we've gotten better and safer with early medication, even in injured patients. They've also been shown ineffective or harmful in some groups, like bariatric surgery patients.
So not a routine thing.
No. Guidelines generally recommend against using them just for prevention because of potential filter complications, like clots forming on the filter itself.
Okay, that covers the mechanical side. Let's switch gears to the pharmacologic methods, the drugs, starting with aspirin.
Right. Good old aspirin. It works by making platelets less sticky, inhibiting thromboxane A2.
And its role in VTE prevention.
It's mainly been studied for extended prophylaxis, meaning continuing prevention after an initial period, especially after orthopedic surgery.
After hip or knee replacement.
Exactly. One trial showed aspirin was non-inferior, basically as good as continuing low molecular weight heparin, or LMWH, after hip replacement. But another trial found no real difference between aspirin and a newer drug, rivaroxaban, after hip or knee replacement.
So a bit unclear.
Yeah, And a meta-analysis suggested maybe similar VTE risk to stronger anticoagulants in ortho patients, but possibly less bleeding risk with aspirin.
Hmm.
It's appealing because it's cheap and easy for patients to take at home, but the debate continues. We probably need more trials to be sure of its place.
Okay. What about warfarin? Coumadin, another old standby.
Yeah, warfarin's been used for therapeutic anticoagulation for ages. It's a vitamin K antagonist. It was studied for VTE prevention in orthopedic surgery, too.
Oh.
But some trials found higher DVT rates with warfarin compared to LMWH after knee replacement, for example. So while guidelines might still list it as an option, the newer evidence generally points towards other drugs being more effective for VTE prophylaxis.
Got it. Let's talk heparins then. Unfractionated heparin, UFH, and low molecular weight heparin, LMWH. What's the difference?
So UFH is the original larger heparin molecule. It works on both factor DEXA and thrombin, mostly by boosting antithrombin.
Yeah.
LMWHs like enoxaparin or dalteparin are derived from UFH. They're smaller fragments. They primarily target factor ZZ. And because they bind less to plasma proteins, their effect is more predictable than UFH. They're mostly cleared by the kidney, so dosage might need adjusting in kidney disease.
And how do they compare for prevention?
Guidelines recommend either UFH or LMWH for moderate to high-risk surgical patients. Studies comparing them. Well, it varies. In abdominal surgery, LMWH had similar VTE rates, but less bleeding than twice-daily UFH in one study.
Right.
In abdominal pelvic cancer surgery, LMWH led to lower VTE rates with similar bleeding. Overall, many meta-analyses tend to favor LMWH in surgical patients because of that potentially lower VTE risk.
What about medical patients? Heart failure, lung disease?
Both UFH and LMWH are effective there too. Some studies suggest LMWH might offer similar or better VTE prevention with maybe less bleeding risk compared to UFH in medical patients as well.
Okay. Then there's fondaparinux, another injectable.
Yes, fondaparinux is a synthetic drug. It's a very selective factor ZZ inhibitor, works very predictably.
And its role?
Studies in orthopedic surgery showed it could be as good as, or maybe slightly better than, LMWH at preventing VTE. Bleeding risk compared to LMWH.
Right.
Some studies say lower, some analyses say maybe higher major bleeding risk.
Yeah.
So bit complex. Guidelines suggest it as an alternative to LMWH or UFH for orthopedic prophylaxis. And it's a safe option if someone develops HIT, heparin-induced thrombocytopenia, because it doesn't trigger that reaction.
Good to know. Now, the newer kids on the block, the direct oral anticoagulants, DOACs.
Right. These are becoming much more common. You have dabigatran, which is a direct thrombin inhibitor.
Yeah.
And then the factor ZOX inhibitors, roxaban, pixaban, edoxaban, petrixaban.
Taken as pills, right.
Exactly. Much more convenient for patients, especially after discharge. They've been heavily studied for postoperative orthopedic prophylaxis.
And how do they stack up?
Pretty well, generally. Trials show dabigatran was non-inferior to LMWH after hip replacement. Rivaroxaban was actually superior to LMWH in preventing symptomatic VTE after hip knee replacement, with similar bleeding. Apixaban seems similarly effective, maybe with even lower bleeding risk. Edoxaban also showed superiority over LMWH after knee replacement.
So pretty strong evidence for orthopedics.
Yes. There's growing support for using DOACs over heparins for extended prophylaxis after patients go home. And rivaroxaban also has an indication for preventing VTE in hospitalized medically ill patients at risk.
That's a lot of drug options. Anything else crucial regarding these medications?
Yes, one really practical point: miss doses.
People not taking their shots or pills.
Exactly. And studies clearly show that missing even 1 or 2 doses of pharmacologic prophylaxis is linked to higher rates of DVT in the hospital.
That's significant.
It is, and it happens often. Sometimes patients refuse. Sometimes it's just missed in a busy hospital day. But the good news is that targeted quality improvement efforts like better nurse and patient education can really reduce missed doses.
So communication and systems are key.
Absolutely.
What about combining methods, using stockings or IPC with the medications?
Definitely. They're seen as complementary, not mutually exclusive. The mechanical methods address blood flow stasis. The drugs address the clotting cascade itself.
Makes sense.
Guidelines often recommend combining mechanical and pharmacologic prophylaxis, especially for highest risk patients. Cochrane reviews and other studies support this, showing added benefit when combining, say, heparin and stockings in colorectal surgery or heparin and IPC after cardiac surgery, leading to fewer PEs. Meta-analyses confirm a significant further reduction in DVT risk with combined therapy compared to anticoagulants alone.
So layering the protection for those most vulnerable.
That's the idea, a multi-pronged attack on VTE.
Okay. Now, the textbook also highlights differences across specific surgical populations. Does the approach change depending on the type of operation?
It does, yeah. The baseline risk, the pattern of VTE events, and the bleeding risk all vary, so you have to
Wow.
tailor the prophylaxis strategy.
Let's run through a few. Vascular surgery.
Higher VTE rates seen after major aortic repairs, chest, or abdomen. And interestingly, about 40% of VTEs in these patients happen after they've gone home.
Post-discharge risk.
Right. Also, many vascular patients are already on antiplatelet or anticoagulant drugs for their artery disease, which might offer some VTE protection too.
Okay. Cancer surgery. We know the risk is high.
Very high. VTE is actually the most common cause of death within 30 days after cancer surgery. And again, a lot of events, maybe a third, occur post-discharge.
Wow.
This has led to studies showing benefit from extending prophylaxis, sometimes for 4 weeks, after certain procedures like laparoscopic colorectal cancer surgery.
Got it. Cardiac surgery.
Here, the bleeding risk during and right after surgery is a major concern. So guidelines often favor IPC over routine drugs for uncomplicated cases like coronary artery bypass grafting, CABG.
Mechanical first.
Often, yes. And one large CABG study actually found no significant difference in VTE or major bleeding between mechanical only, drugs only, or combined therapy. So maybe less benefit from adding drugs in routine cases there.
Interesting. Bariatric surgery, weight loss surgery.
Very high VTE risk here due to obesity itself and often other comorbidities. Dosing of LMWH often needs to be adjusted upwards. Studies show higher doses work better.
Okay.
And again, a very high rate of post-discharge VTE, like 73% within 90 days in one study. So extended prophylaxis is common practice for many bariatric patients.
Neurosurgery. Brain and spine. That sounds tricky.
Extremely tricky. High VTE risk from factors like immobility and sometimes underlying conditions like cancer, but also a catastrophic risk from bleeding in the brain or spine.
Right.
So IPC is generally preferred initially. Pharmacologic prophylaxis might be added later for high-risk patients, like those with brain tumors, once the immediate bleeding risk subsides. But it's a delicate balance. And PE remains a significant cause of VTE-related death in these patients.
Trauma, major injuries.
Also very complex. High risk for both bleeding and clotting. The data tends to support LNWH over UFH for VTE prevention here, seems to lead to fewer DVTs. And this is one area where temporary IVC filters might have a role if anticoagulation is absolutely impossible due to bleeding.
And finally, orthopedic surgery. Hips and knees again.
Yeah, a major focus area. High VTE risk from the procedure, bone manipulation, immobility. Guidelines generally recommend at least 10-14 days of pharmacologic prophylaxis, often favoring LMWH, plus IPC.
But other options exist too.
Yes. Guidelines also mention warfarin, aspirin, and the DOACs as possibilities, depending on the specifics. It's an area with lots of research and evolving practices.
It's clear that VTE prevention is vital but complex. The textbook also mentions challenges in actually getting this done consistently in practice.
That's a really important point.
Yeah.
Despite all this evidence, VTE prophylaxis doesn't prevent every clot. And historically, there's been a big gap between guidelines and practice.
Underuse of prophylaxis.
Yeah. Studies have shown less than half of hospitalized patients who should get prophylaxis actually received it optimally. And we know that just educating doctors and nurses isn't enough. You need active strategies, system-level changes.
And that's where organizations like AHRQ come in.
Exactly. AHRQ has championed VTE prevention as a top patient safety practice. They provide resources, toolkits for hospitals to improve their processes, things like embedding risk assessment tools and alerts into electronic health records.
Computerized decision support.
Right, to prompt clinicians at the point of care. The best practice really involves a reliable system for risk stratifying every patient, prescribing the right prophylaxis based on that risk, and then auditing to make sure patients actually get it.
So assessment, prescription, and confirmation.
That's the core loop for effective prevention in hospitalized patients.
The text also gives a nod to some key references that really shape the field.
It does. Dr. Caprini's original work on the risk score, obviously foundational.
Right.
The AHRQ chapter by Hott and Lau really framed VTE prevention as a key patient safety issue. The CHEST guidelines are the go-to source for detailed recommendations for non-orthopedic patients. Dr. Maynard's work provides practical advice on how to implement quality improvement for VTE prevention. And that Surgeon General's call to action in 2008 was really pivotal in raising national awareness.
So, wrapping this all up, the big picture is VTE is serious, common, potentially deadly, but
it's often preventable. That's the crucial message. We understand the risk factors pretty well now.
And we have effective tools, both mechanical and pharmacologic.
We do. The key is using them appropriately, assessing individual risk and choosing the right strategy or combination of strategies for that specific patient.
This has been incredibly informative, really unpacking the layers of risk and prevention. It highlights just how much goes into keeping patients safe from this specific threat.
It really does. It's a constant effort to apply what we know effectively.
Which brings us to a final thought for you, our listener. Given how significant VTE is and that we have these proven preventative strategies, what do you think are the biggest ongoing challenges or hurdles to ensuring that everyone who needs it gets the right VTE prophylaxis consistently across all the different hospitals and healthcare settings? Something to think about as you consider healthcare quality and preventative medicine.